Okay, today our topic will be coronary heart disease. It is also known as ischemic heart disease. Now we will see its definition. Basically, it is the ischemia, meaning less supply of oxygen to the heart. It is an imbalance between the coronary oxygen demand and supply, resulting from insufficient blood flow, meaning the demand is more but the supply is less, which is leading to the ischemia of the heart. So we will see its clinical features. It can be asymptomatic, or it can have a stable angina, meaning there will be a chest pain. Uh, there can be acute coronary syndrome. In acute coronary syndrome, is an unstable angina, myocardial infarction, ST elevation MI, known as STEMI, or non-ST elevation MI, known as non-STEMI. Okay, there can be a sudden cardiac death. The risk factors can be hypertension, the most common risk factor. If you are prone to hypertension, by whether it can be acquired or it can be hereditary, and if you have diabetes mellitus, there's a risk factor, and it is the most worst risk factor, meaning that it it is having the worst prognosis. There can be a cigarette smoking. In the risk factors, always rule out cigarette smoking in the patients. There can be hyperlipidemia. Either it can be familial or acquired. Uh, Age is important. Man greater than 45 years, woman greater than 55 years. Keep that in mind. And a family history of chronic heart disease in the first degree relative. If you have a male relative less than 55-year-old having the problem, then you can have the problem in the family history. If you have a female relative less than 65 years old having the problem, then you can have the problem as well. But it applies to first degree relatives only. Okay, chest pain of cardiac origin. If the chest pain of cardiac origin, there can be many reasons. Different DDs apply. It can be either due to GERD or any other problem. It can be referring from the some kind of nerve, um, from the viscerals. Okay, if it is of the cardiac origin, it is uh, central and diffuse. Okay, you cannot localize it. That's the most important point. You cannot localize it. It is diffuse. If it is coming from the vagus nerve, it will refer towards the your shoulder points, top of the shoulder. But if it's of the cardiac origin, it will be central and diffuse. It is gradual in onset, meaning it is not sudden, and it takes several minutes to develop. Most probably less than 30 minutes in angina and greater than 30 minutes in myocardial infarction. Okay, uh, the it is dull, constricting. Dull means throbbing pain. Someone is hitting you with their fists, and it can be constricting uh, and crushing and choking in character, like someone is holding you in their arms and choking you or constricting you. It may radiate to the neck, jaw, and arm. Okay, this is it will involve left arm in most of the cases. Okay, it occurs during, not after exertion, during exertion, but also occurs during immersion and in cold wind. It is relieved by rest and nitrates in angina, nitroglycerine. You can give it sublingually. Okay, it is usually associated with breathlessness, uh, sweating, nausea, and vomiting. No changes with respiration or position of the body. If the chest pain is of cardiac origin, okay, these are some of the signs to diagnose if it is of the cardiac origin. Okay, these are some of the different differential diagnoses of the chest pain. It can be disease syndrome. If you have a problem in the costochondritis, meaning the inflammation of the costal bones, it presents with chest wall tenderness. There's aortic dissection. If the aorta is being dissected, it can have a tearing chest pain relating to the back because the aorta is present in the back. Unequal blood pressure between arms. Okay, pain can be due to the pericarditis, the inflammation of the pericardium due to some infection. It can either be bacterial or viral. The chest pain that changes with position of the body. Uh, Actually, when the patient sits or leans forward, the pain changes, meaning the pain is lessened if he leans forward. And chest pain aggravates when lying flat because the venous return increases when you are lying flat, and it also improves when sitting up or leaning forward. Okay, the next DD can be gastroesophageal reflux. It is the chest pain which is burning in nature. It occurs due to the uh, relaxing effect of the sphincter. The sphincter relaxes and allows the food content to come up, which can cause the irritation of the esophagus, and it can cause bad taste, cough, and hoarseness. The next one is pneumonia. It is due to the uh, cough sputum, hemoptysis, or fever, and consolidation is seen on the chest X-ray. It can also occur due to pulmonary embolism. It is sudden onset of shortness of breath, and it is marked with tachycardia, tachypnea, shortness of breath. Tachycardia means the increase in heart rate, and hypoxia meaning less oxygen. It can also occur due to pneumothorax. It can The pneumothorax means the air in the lungs. Pneumo means air. Thorax means the lungs or the abdomen. Uh, sorry, chest. It can be sharp, lyric pain, and it is aggravated with inspiration. You can find tracheal deviation because when there is lot of air in the lungs, it will cause the trachea to shift on the opposite side because of the pressure that is building up due to the air. Then there is the peptic ulcer disease. It causes epigastric discomfort, and if there is a duodenal ulcer, it is relieved with food. Gastric ulcer is aggravated with food. Okay, then we come to the stable angina. It refers to the substernal chest pain. Okay, this is a person neck. Okay, this is trachea. Okay, this is lungs. Okay, and before it, this is a sternum. This is the sternum. The rib cage is uh, going out from it. So the pain is here on the sternum. Okay, the pain is here on the sternum, and it is behind the sternum. The substernal chest pain secondary to myocardial ischemia is a sign of stable angina. In its pathogenesis, it is the ischemia due to fixed arteriomatous stenosis of more than one coronary arteries. This is an atheromatous stenosis. The plaques are formed in the heart and they are causing the restriction to the blood flow. Okay. The clinical features can be substernal chest pain of 5 to 15 minutes duration. It can be relieved by rest or by nitrates, nitroglycerin given sublingually, aggravating by physical exertion, heavy meals, cold exposure, and intense emotion. Pain may radiate to jaw, neck, and arm. Pain may be associated with nausea, vomiting, and sweating and lightheadedness. Okay, you can do investigation by doing ECG. It is the best initial test. Best initial test is the ECG. Sign of myocardial ischemia is ST depression and T wave inversion. Okay, this is a very important point. The ST depression or the elevation. If it is elevating, then it is infarction. If it is depressing, it is ischemia. This is a very important point. You can remember by in is elevation is in infarction and depression is in ischemia. This is a very important point to remember. And additionally, you can find a T wave inversion. It is usually normal in patients with stable angina. The ECG is usually normal in patients with stable angina. Okay, see, you can also do exercise ECG. It is also known as exercise tolerance test, ETT, exercise tolerance test. It is done by exercising the patient. It involves a treadmill. The patient walks on a treadmill. The ECG is recording before, during, and after the exercise on a treadmill. A patient with positive stress test should undergo cardiac catheterization. The catheter is passed. If there's a positive stress test, meaning there is changes in the ECG during the exercise. If the sensitive It is sensitive if the patient is able to increase heart rate to 85% of the maximum. Whatever your age is, minus 220 from your age. For example, your age is 23, so I'll minus, for example, your age is 20, not 23. Okay, 20. The heart rate, your maximum heart rate will be 200. Okay. Signs of myocardial ischemia to look for on ECG. Okay, drop down sloping of ST depression ischemia. Already told you uh, the depression indicates ischemia, the elevation indicates infarction. Okay, and if the patient cannot exercise, we give him thallium scan, dipyridamole, thallium scan, which causes exercise of the heart, and we can detect it by the electrocardiography, or you can do it by the dobutamine doing electrocardiography. If you're using dipyridamole, you can use the thallium scan. Okay, the thallium scan, it is used if the patient cannot do the tolerance test or unable to exercise. We can give him two types of stresses, exercise or pharmacologic. The pharmacologic is given by dipyridamole. Okay. If there's reversible ischemia, if the reversible ischemia means if you rest, the ischemic damages are reversed. Irreversible ischemia means they cannot be reversed on the resting. Okay. Then there's stress echocardiography. It is an alternative to myocardial perfusion scanning. It uses transthoracic endocardiography. Okay, and we can induce the types of stress by exercise or pharmacologic using dobutamine. If there's reversible ischemia, there's decreased wall motion during stress. Decreased wall motion during stress. If there is irreversible ischemia or infarction, there is decreased wall motion during stress and at rest. Meaning, when you are doing the exercise, there is decreased wall motion because there is ischemia. And when there's ischemia, that ischemia is even present when you are at rest, then means the ischemia was irreversible. Okay, it cannot be reversed because it has done enough damage to the heart already. Okay, now there is coronary angiography or arteriography. It is used to detect the anatomic location of the coronary artery disease. It is the most accurate test. It provides information as to which the procedure is preferable. Okay, it will tell us which procedure to do. Either we'll do the coronary artery bypass graft or we can do percutaneous coronary intervention. It is the PCI is the recent procedure. This is more modern procedure and it is done very much these days. It is done by stenting, placing a stent by the balloon method. You inflate the artery by ballooning it and then will pass a stent. Okay. In the coronary artery bypass graft, you will take the bypass from the saphenous vein, or you can take arterial graft of the mammary artery or radial artery. Okay. Okay. Exercise tolerance test. Ischemia is detected by ST segment depression. Exercise echocardiography, dobutamine. Echocardiography, ischemia is detected by wall motion abnormalities. Exercise therium, dipyridamole therium, ischemia detected by perfusion defects. Okay, moving forward, how we will manage it. First of all, we'll do lifestyle modification. We can do antiplatelet therapy. We can give anti-anginal therapy, and okay, we can do revascularization therapy. Okay, these are the four modalities, and we will discuss them one by one. Okay, what we can do in lifestyle, we can do smoking cessation always, or the history of smoking of the patient. Weight reduction. If the patient is obese, we advise him to reduce his weight. Regular exercise, diet, induce intake of saturated fat and cholesterol to less than 200 mg per day. Control the blood pressure. We can also treat hyperlipidemia, decrease cholesterol intake, and the statins are most important. We'll give statins to everyone. Simvastatin, HMG-CoA reductase inhibitor statins to reduce the cholesterol. What are our ideal values? 40, above 40 SDL, less than 100. LDL, the tax less than 150. Okay, less than 150, greater than 40, less than 100. These are all ideal, uh, you know, uh, treatments, the ideal numbers. Okay, we'll give antiplatelet therapy. We can use aspirin. We will give aspirin to every patient because it reduces the mortality. It reduces the mortality. It reduces the mortality. It reduces the mortality. It is indicated in all patients with CAD, coronary arterial diseases, because it reduces mortality. It should be given as low dose 75 mg daily indefinitely. Clopidogrel. It either you can mix it with aspirin, or if the patient cannot tolerate aspirin, you give clopidogrel. If the patient cannot tolerate aspirin, you give clopidogrel. It is equally effective as aspirin, given 75 mg daily. It is given for those who cannot tolerate aspirin, or after an operation. Okay, anti-anginal therapy, anti-anginal therapy. We give nitrates sublingually. We give beta blockers to relax the heart. We give calcium channel blocker to relax the ECG, because the ECG is very rampant when you not give the calcium channel blockers. We can give potassium channel activators, IF channel antagonist. We will see the nitrates. What are the nitrates? It is the glyceryl trinitrate GTN, which cause the venous and arterial dilation, means dilated artery, more blood, and the more perfusion, less ischemia. Dilated artery, more blood, more perfusion, less ischemia. Okay, these agents decrease both preload and afterload. These agents both increase both preload and afterload. GTN can be given orally, sublingually, transdermally, or intravenously. If the patient is dying on you, you will give it sublingually to eliminate the bypass effect, and uh, to eliminate the metabolism in his liver, and you will use the first pass effect. Okay. GTN undergoes extensive first pass metabolism in liver, and it is ineffective orally. So we will bypass the first pass effect by giving it sublingually. We will bypass the first pass effect by giving sublingually. Side effects can be headache, orthostatic hypotension. Okay, next comes the beta blockers. They block the sympathetic stimulation and lower myocardial O2 demand. They relax the heart. Suppose your heart is beating like this, then it will beat like this, because it will be more relaxed. So it will lower the myocardial oxygen demand. There are two types, the selective and the non-selective. The selective blockers are metoprolol, are better tolerated than non-selective beta blockers, propranolol. So give metoprolol. The selective beta blockers A to M are selective, and after M are not selective. N to Z, not selective. It is a mnemonic to remember it whether the blocker is selective or non-selective. The side effect, it can cause bronchospasm. Do not give it in asthmatic patients. Do not give it in asthmatic patients because it will cause bronchospasm and the patient will die on you. It can cause withdrawal syndrome. Abrupt withdrawal of beta blockers may have a rebound effect and precipitate dangerous arrhythmias or MI. Okay. Calcium channel blockers, it can cause coronary vasodilation. They cause vasodilation. Other thing that caused vasodilation was nitrates. Very good. And the afterload reduction. Dihydropyridine, calcium channel blockers. These are nifedipine and nicardipine. The dipines, D-I-P-I-N-E, are always calcium channel blockers. The dipines are calcium channel blockers. Other ones are verapamil and diltiazem. The verapamil, diltiazem, dipines, verapamil, and diltiazem. Okay, they can cause reflex tachycardia and are given with beta blockers. The dipines are given with beta blockers to reduce the tachycardias. The non-dihydropyridine calcium channel blockers are verapamil and diltiazem. These agents must not be given with beta blockers as it may result in profound bradycardia. They can cause bradycardia. So they are not given with the calcium channel blockers. Okay. It is therefore suitable in those who cannot tolerate beta blockers. Who cannot tolerate beta blockers, meaning asthmatics. Very, very important. If you give it in asthmatics, it can cause bronchospasm and the patient can die. Side effects: myocardial depression or heart failure. It can cause constipation, peripheral edema, flushing, headache, and dizziness. Okay, then the patient is red actually in the calcium channel blockers. The patient is red. In potassium channel activators like nitrates, these agents cause venous and arterial dilation. Okay, Ivabaradine is the first of this class, and it acts on the inward current of the sinoatrial node, reducing the heart rate, but will still prefer or nitrates or beta blockers. Okay, yes. Now comes the revascularization therapy. It is percutaneous coronary angiography, the PCI, and the most modern technique, commonly referred to as angioplasty. It is with the balloon and then stenting. The ballooning and stenting. The ballooning and stenting is the characteristic of the PCI, percutaneous coronary angiography, often known as angioplasty. Indications: with XT segment elevation in the ECG. Elevation means infarction. ST elevation means infarction. ST elevation means infarction. Okay. It should be considered in a single or two vessel disease. Single or two vessel disease. If there is a blockage in single or two vessels, you will give PCI. Should also be considered in three vessel disease, three stents at a time. Stable angina provides symptomatic relief but is unclear if it improves survival in chronic stable angina. The complications can be acute occlusion of the target vessel, It occurs in 2 to 5% of the procedures. It is due to the occlusion of vessel by thrombus formation or coronary artery dissection. If the complication is chronic, then you can cause the it causes the restenosis of the dilated vessel. It can occur within 3 months. It is due to the combination of elastic recoil and smooth muscle proliferation, meaning it will like start growing on the stent and then block the artery, and it is a complication. Okay, CABG, coronary artery bypass grafting. It is like opening of the chest wall. This is like the chest, and this is the heart. They open it from here and do the surgery of the heart directly and placing stents or doing they will graft it using the saphenous vein, the internal memory artery or the radial artery. Okay, they have a long-term patency. 50% of the vein graft are patent after 10 years, while 80% of the arterial graft are patents after 10 years, meaning they are like working after even after 10 years. But 50% of the venous graft fail, while 80% of the arterial grafts are successful even after 10 years. Indications. What are the indications of the CABG? Three vessel disease. Three vessel disease is the first indication, with at least 70% stenosis in each vessel. Like this is a 70% stenosis. Okay, this is the blockage. This is the opening, the remaining opening. This is a 50% disease, and this is a 25%. Okay, blockage. So if there's at least 70% stenosis, we'll do the CABG. So the arteries including are the left anterior descending, circumflex, and right coronary arteries. If the patient is diabetic with two vessel occlusion, then we'll do the CABG. Okay, okay, mortality. It can cause PCI causes less than 0.5 mortality, and CABG causes more than 1.5 mortality. Myocardial infarction 2%, CABG causes 10%. Hospital stay 12 to 36 hours. CABG causes 5 to 8 days stay. Return to work 2 to 5 days. CABG 6 to 12 weeks. Logical complications rare. No neurological complications. CABG common complications. Recurrent angina more common because the stents can be occluded again. Less common because you put a new graft, so less chances of occlusion again. Okay, the variant angina also known as penzimetal angina. Oh, okay, ECG transient ST elevation, not depression. ST elevation, not depression. Infarction. Okay, we will cover these in the next video. Thanks for watching.